প্রেজেন্টেশন যেখানে শেষ করবেন আমরা কিন্তু একটু ইন্টারাকশন চাবো। বিশেষ করে আমরা চাবো অডিয়েন্স যাতে একটু ইন্টারেক্ট করে, কারণ আমরা চাচ্ছি যে এটা একটু ইন্টারেক্টিভ সেশন হোক। ওকে, ডাক্তার ইউসুফ আলী প্লিজ।
ওকে, থ্যাংক ইউ এহসান ভাই। আমার স্ক্রিন দেখা যাচ্ছে?
ক্লিয়ার।
ওকে, ওকে, গুড ইভিনিং, আসসালামু আলাইকুম। Really, it's an honor and a pleasure to talk in a big platform like BD Physician in front of two renowned physicians of India. And I am really delighted to have this opportunity to talk. Uh, this is I myself, Dr. Mohammad Yusuf Ali, consultant medicine, 250-bed district hospital, Madripur, Dhaka, Bangladesh. Uh, First of all, I like to congratulate Sir, especially the chairperson of today's session, Professor Jyotirmoy Paul Sir, Professor of Medicine, Sagar Datta Medical College, and Dean, Indian College of Physicians, and very well-known person of us, doctors of Bangladesh, that is Dr. Parveen Yadav Sir, Senior Consultant Medicine and Associate Professor, and he is also Chairman of Aerogym Neuro Clinic. Uh, today actually this is a opportunity that I took to talk in front of this learned and renowned physician. I'm really delighted again. So what I will do, I will share a case, neuro case, especially to I will share it with the panelists to enlighten myself and my fellow junior doctors, colleague of Bangladesh, especially. And these topics, I think, this case we encountered. This is a very important case for especially those who are FCPS and MRCP candidate, those who will appear very soon. This is a very important case, I think. And but the aim of presentation of today is that this case is not yet settled. This diagnosis is not still made. Conformity diagnosis is not still made. Okay. So with the permission of chair, I am going to share my case. Sir.
Please proceed. Please proceed.
Thank you, sir. Actually, this is a story of a young male, 22 years. The boy is suffering a lot, and really he's frustrated now. And his main complaint is now that I will not, sir. First of all, I like to share that I will not present this actually as a complete long case or complete short case. I will just share the tale of a young boy who is suffering from a Bangladeshi boy. Okay. So this young male, 22 years, he's a student, varsity student, and suffering from tingling numbness of both upper and lower limbs for 6 months. This is the only complaint, presenting complaints now. But he had history of recurrent visual loss for 3 times in the last 6 years. I took the photo with the permission of this boy. He's very much eager to find out a diagnosis. He's a student, and he noticed 7 years back in 2016 that sudden loss of vision in left eye after just getting up from bed in the early morning. He was puzzled, and he visited to a nearby eye specialist in Dhaka, Bangladesh, and he was treated with prednisolone, high doses prednisolone. He mentioned that, and later one for only 7 to 10 days, and he had a complete recovery. It was 2016, and he at the same time he was also referred to a neurologist for further management. The neurologist did some investigation, that is MRI, brain, spinal cord, and all the investigation, including routine test, was normal at that time. 6 months later, he again developed blurring and pain in his right eye, and he visited to neurologist, and the neurologist immediately advised to admit him and treated with IV methylprednisolone 1 gram for consecutive 3 days, and followed by prednisolone for a month and mycophenolate mofetil for continue, keeping in mind some differential diagnosis. In 2018, again, third time, he developed eye pain on movement, and also loss of blurring of vision. And this time, he's again treated with IV methylprednisolone for 5 days and MMF for continue. He had complete recovery. In this time, there is also this patient did MRI brain, spinal cord, fundoscopy was normal, and also do some vitamin B12 level. All this investigation was done, but there was no clue. The boy is hypertensive, recently diagnosed. He's taking losartan potassium 50 milligram daily. The boy is not diabetic. As I took history retrogradely, that is, I have seen this patient just 1 week back. I uh, I tried my best to find out any history, relevant history, but the boy denied any history of fever, headache, loss of consciousness. There was no convulsion, slurring of speech, or swallow problem, no memory problem, or no particular limb weakness, any weakness he denied. But he complains of being fatigued day by day. He mentioned that he feels fatigue just after doing some activity, just like this. His fatigue, there was no diurnal variation, or it was not much at the end of the day. There was one query. He also denied there was no history of neck pain, back pain, joint pain, rash, any color change of the finger. There was no mouth sore or sore in the private part. No history of cough, shortness of breath, no lumps and bumps in the body. There was no history of heat or cold intolerance, shaking of the limbs, or any excessive sweating. I especially ask about bladder symptoms. That is there any problem in urination? But the boy denied any history of hesitancy, urgency, or there was no history of retention of urine or any incontinence. His bowel habit was also normal. Regarding past medical history, it was not significant. He was not suffering from any long-term medical condition. There was no surgery, blood transfusion, but he was hospitalized for 3 times only for methylprednisolone that I mentioned it earlier. Regarding drug history, the boy is currently taking antihypertensive, losartan potassium, some vitamins, thiamine, vitamin B6 and B12, pregabalin. That's all. Family history, I ask about family history. Is there any family member suffering from this type of illness? He denied. There was no significant family history. Regarding as a young boy, I also take sensitive history regarding personal history. Like he denied any history of smoking, alcohol. With the permission, I ask about IV drug abuse. No, there was no history of IV drug abuse or sexual exposure. With the permission of the patient, I asked this sensitive question. Again, there was no history like that. His dietary habit was normal. He's not vegan. And there was no previously psychiatric admission. Okay. And I examined the patient thoroughly. That now the patient only complaint is that he's suffering from just tingling numbness of both upper and lower limb. Otherwise, he's fine. And some weakness, some his word, that is fatigue. In general examination, I found nothing. He was absolutely okay, but little bit anxious. Neurological examination, including higher psychic function, cranial nerves, motor examination, sensory cerebral sign, including fundoscopy, is normal. And fundoscopy was normal every time of his presentation earlier. That is when he developed vision loss. Other system, including relevant cardiovascular system, there was no murmur. I searched for the murmur for any embolic phenomena. There was no murmur or any known heart disease. Respiratory system, muscular system, and endocrinology was normal. That is absolutely examination finding was normal. So this is the tale of this is a short. I will say this is a short history of this boy. So with this finding, the boy was already got some treatment and he was improved by repeated times by taking methylprednisolone. He was given IV methylprednisolone for his visual symptoms only, and he's now fine. His vision is absolutely normal now. And recently, fundoscope 1 week back, his fundus was normal. I have seen his fundus, and so far it was absolutely normal. I cannot collect his previous MRI film. It was normal, so I don't give importance on that. And I could not collect it actually. The boy was discharged day after. So with this history, we have.
ওকে ডাক্তার ইউসুফ, আমি একটু কোশ্চেনস নেই, আপনি এখানে থাকেন। ওকে ডাক্তার ইব্রাহিম খলিল, আপনাকে আমি অ্যালাউ করছি। আপনার কোনো কোয়েরি আছে এখানে?
Assalamu alaikum. I am Dr. Ibrahim Khalil. So I have some question about the investigations, like the fundoscopy is normal. Okay, all right.
I think first there will be discussion on history and clinical presentation, whether there is any lacuna, কোনো কিছু মিস হয়েছে কিনা আমাদের, তারপরে আমরা ইনভেস্টিগেশনে যাব।
না স্যার, আমি ওকে, ঠিক আছে, আপনি মানে হিস্ট্রি পর্যন্ত কোশ্চেন করতে হবে, ইনভেস্টিগেশন না।
হিস্ট্রি এন্ড এক্সামিনেশন,
হিস্ট্রি এন্ড এক্সামিনেশনের মধ্যে থাকেন। ডক্টর মাকসুদা পারভিন, ওকে। ডক্টর ইব্রাহিম খলিল, যতটুকু প্রেজেন্টেশন হয়েছে এর মধ্যে থাকেন, হ্যাঁ?
Okay, then I have the question about the fundoscopy. Like, if we could see the fundus, like if there is in picture, like I'm saying, the fundus was all right, but is there anything that we can pick up from the fundus? If the visual field and the full optic examination was done in the patient, like the visual field and any other visual field defect or visual acuity.
No, I mentioned that all the examination finding was normal, physical examination, including cranial nerves. Okay, there was no visual acuity, visual field, color vision, everything was normal, fine. Even at the time of presentation, patient had lost his vision, just a total loss of vision. First of all, left eye, then 6 months later, right eye. Okay, at that time. So at that time, neurologist did fundoscopy examination. There is document their fundoscopy was normal, and even the MRI. This boy did MRI for 3 times. Okay, and every time.
Okay, Dr. Yusuf, আমরা বুঝতে পারছি। আমি নেক্সট কোশ্চেন নিচ্ছি ডক্টর মাকামাম। জাস্ট যতটুকু প্রেজেন্টেশন হয়েছে এর মাঝে কোশ্চেন করতে হবে। ডক্টর মাকামাম মাহমুদ, পরিচয় দিয়ে প্লিজ কোশ্চেনটা করো। বাংলায় করতে পারো, কোনো সমস্যা নেই।
আসসালামু আলাইকুম স্যার। স্যার, আমি ডক্টর মাকামাম, আমি অ্যাসিস্ট্যান্ট হিসেবে কর্মরত আছি রাজশাহী মেডিকেল কলেজ হসপিটালে, মেডিসিন ডিপার্টমেন্ট। স্যার, আমার প্রশ্নটা ছিল হচ্ছে পেশেন্টের কি কোনো সেরেবেলার সাইন ছিল কিনা যখন আমরা হচ্ছে এক্সামিনেশন করা হয়েছে, বা কোনো পেশেন্টের ট্রেমর, এই যখন তার এপিসোড গুলো হয়েছিল সে সময় কোনো অ্যাটাক্সিয়া এরকম কোনো হিস্ট্রি দিয়েছিল কিনা। আর পেশেন্টের যেহেতু পেইন সেন্সেশন, মানে একটা টিংলিং সেন্সেশন ছিল স্যার, সেখানে হচ্ছে এক সাইড এবং অপোজিট সাইডে কোনো মানে ডিফারেন্স ছিল কিনা, এখানে পেইন সেন্সরি ডেফিসিট ছিল কিনা, থাকলে কতদূর পর্যন্ত, আর হচ্ছে স্যার জয়েন্ট এবং পজিশন ভাইব্রেশন সেন্সেশন এগুলোর কি অবস্থা ছিল স্যার, এটা একটু কোয়ারি ছিল আমার।
Okay, in the history I mentioned there was no limb weakness. Okay, and there was no memory problem like convulsion and slurring of speech, swallow problem. And you mentioned that there is no tremor. Okay, shaking of the limbs. Okay, there was no history of shaking of the limbs, and there was no walking difficulty also, because there is no limb weakness. Okay, the gait was also normal. Although it's mentioned here, examination finding including all neurological examination now patient now and in the past. He also mentioned that at that time all the findings was normal. Okay,
পেইন এবং নামনেস যেটা ছিল স্যার, সেটা কোথায় ছিল এবং কতদূর পর্যন্ত ছিল স্যার? এটা
both upper and lower limbs now for 6 months. Numbness is now he developed for 6 months tingling and numbness. Okay, initially there was no tingling and numbness, initially only like visual loss for 3 times. Okay,
sir, both side naki single side ashole,
and 2029 the third time only visual loss first, then patient developed for the last 6 months.
Okay, visual loss both side e chilo doctor, so both side e chilo ei to
ha, first left eye then right eye.
Okay, Dr. Praveen Yadav,
tingling এবং নামনেস টা কি স্যার both side এ ছিল নাকি এটা জানতে চাচ্ছেন?
both upper and lower limb, both side, both upper limb, lower limb,
both side স্যার।
Okay.
Ehsan Khan, if we discuss like this, I think we are not going to end anywhere, you know.
Okay, okay. তাহলে
So-
আমরা কোশ্চেন শেষ করলাম। আপনি এখন
Few
ডাক্তার
spe-
প্রবীণ
few
কুমার যাদব and
specific
চেয়ারপারসন।
questions.
Okay. So
Yeah,
so may I
few
proceed?
specific question. Was there any RAPD, relative afferent pupillary defect in the eyes? Was it documented? RAPD was there or not?
No, sir. There was no documented RAPD. RAPD actually
Because,
at that time presentation there was no documentation.
Okay, and second thing is, did you get a ophthalmology opinion, and was there any minor temporal pallor in the fundus? Because sometimes the fundus may be normal, only temporal pallor may remain, and vision may be normal.
Yes, sir.
So was the ophthalmology
no, sir,
opinion done with a
The
dilated
patient was
proper?
referred for patient poor cooperation. We cannot do that. There was some
Okay.
financial
So
issue.
now
Also,
the
patient
thing
was
is,
not much
see,
cooperative at that time. This time, so we don't give
Yeah,
any
yeah. So
text
this
to the
fundus means
photograph
bedside
and also
fundus,
other some
bedside fundus
later on I
evaluation.
will show you. Yes, bedside
Yeah,
fundus
bedside
was done.
fundus evaluation may not be. Yeah, so that may not be very correct, you know. You have to get a proper ophthalmology. Sometimes minor temporal
Yeah.
pallor may be missed. Now, I think you go with the symptom like visual loss, alternate eye visual loss. So this was the initial
Yes.
symptom. So according to you, the site of lesion is in the, where is the site of lesion and what could be the etiology? So what do you postulate? What it could be?
Yes.
Cause of
Yes, sir. Sir, we kept
visual
some
loss.
differentials in my mind. That is, multiple sclerosis was top.
And then the
top in my
tingling and
differentials.
numbness you can localize where.
আচ্ছা আমি একটাই
No,
কোশ্চেন
multiple sclerosis is a
No,
diagnosis.
Okay, sir.
You have to
Professor
say,
Jyotirmoy sir, please. Jyotirmoy sir.
নেক মুভমেন্টে কোনো ইলেকট্রিক শক লাইক সিম্পটম ছিল?
No,
Neck
sir. No,
movement.
sir. There was no neck pain or there was no what we call Lhermitte sign. There was no such feature, sir. That neck flexion. There was no exhibiting of the pain in the upper limbs or lower limbs. There was not such sign, sir. The
Okay,
sign was
fine.
negative. I tested that.
So what is your differential diagnosis, anatomical site of lesion, and what can be possible
So
etiology?
anatomical is a young boy, history of recurrent optic neuritis as we kept in and it was more than 2 attacks. So suggestive of MS, not confidently defined MS. We all know that we for clinical diagnosis we need at least 2 objective finding like optic neuritis or optic atrophy or pyramidal weakness, cellular sign, and so and some hemiparesis or spastic paralysis like that. But there was no objective finding now of this patient is having. We know that in MS there may be some subclinical lesion also, but so that we do MRI for third times, even after MRI doing third time, it was reported as normal. So dilemma is here. So now question is that should we new evaluation for MS is needed or not, or is it clinically isolated syndrome?
yeah.
So this is the dilemma
See,
here.
here
And
the
another
thing
one
is-
is another differentials was neuromyelitis optica.
Okay,
Because
Dr. Yusuf, আমরা প্রথম ডিডিতে থাকি। Dr. প্রবীণ যাদব।
See, here you can say that the site of lesion is in the optic nerve. Now, optic nerve can be involved by many pathologies. It may be demyelinating disease like MS, NMO, MOG, whatever you are saying. Second is it could be some ischemic lesion also, because a young male patient, he is having hypertension. So it could be some vasculitis affecting the optic nerve. That can again give rise to painful visual loss. But vasculitis, usually it will not recover so rapidly. And there will be some residual visual involvement. So here there is complete recovery.
There was no feature of vasculitis. We took the history of regarding any feature, any symptoms. There is purpuric rash, joint pain. They are not suggestive. Even possible, sir.
And then second, the localization you said.
Then second diagnosis was differentialitis and optic neuritis both, but sometimes there may be isolated optic neuritis or isolated myelitis may occur. So we kept neuromyelitis optica in the second differentials, and keeping in mind that neurologist may be prescribed this patient MMF, mycophenolate mofetil, for long-term immunosuppression in case of neuromyelitis optica, because this boy was getting a long time. Okay, But unfortunately, the anti-NMO may be positive in 80% cases. Some portion may be negative, even neuromyelitis optica disorder. And so the third differential was anti-MOG disease, but history was not suggestive because there was no actually encephalitis like which disease, and sir will enlighten us more. Parvin sir and Professor Jyotirmal sir. Sir, vitamin B12 deficiency is less likely because there was no feature suggesting of no history of causes of vitamin B12 deficiency, any malabsorption or any pernicious anemia, no feature like that. And dietary history is normal. There was no anemia, optic atrophy, and CBC is completely normal, sir. So that's why vitamin B12 deficiency is very much less likely. Although this is vitamin B12 level was done, it was even normal. And fourth differential was vasculitis, sir. You said earlier that there was no history suggesting SLE, rheumatoid arthritis, EGPA, or PAN. Even other vasculitis, there was no purpura, no joint pain, rash, photophobia, or any feature suggesting vasculitis. Only other than hypertension. Patient is hypertensive.
See, first prominent symptom was eye. Second was the tingling and numbness of the hands and feet. So here the localization will be either in the cervical cord or it could be in the peripheral nerve also. It could be peripheral neuropathy also. We do not know. So that also you have to keep as a possibility. Now, if it's in the cervical cord, then you think of a demyelinating disease like optic nerve and cervical cord. If it is peripheral neuropathy, then you think of other causes like vasculitis and other things. So that the examination and the further investigation will tell you whether it's a peripheral neuropathy or a cervical cord pathology. So this also a possibility you have to keep. Now, what about the visual loss in NMO and MS? How is it different, like clinically?
Sir, in NMO, usually there is bilateral optic neuritis, maybe, sir. At the there may be the bilateral optic neuritis, but this patient has also bilateral, first left, then right, after 6 months.
No, NMO will cause simultaneous, severe, non-recovering bilateral optic neuritis. So it will not resolve very fast. They'll have some neurological deficit. Fundus may be abnormal, and there may be some residual deficits. And the MRI will show lesions because it is long optic nerve involvement. So you get high intensities in the MRI, which will be with the history because it is alternating optic neuritis, and there is good recovery. So it's likely to be MS-like pathology or whatever you have said, CIS, clinically isolated syndrome.
Yes, sir. Okay, sir.
Sir, would you like to add anything, sir? Sir?
Yes.
Sir,
Yes,
any differential
continue.
want to add, sir, from your side?
Okay, continue. Professor Minal Kantira want to add something. He raised his hand.
Ehsan Khan, can you allow sir to speak?
Professor Minal Kantira has raised his hand. Okay, continue. Let him be included in the panelist link.
Okay.
Then we'll
Sir,
listen from him.
investigation that was available, that was done previously, that is MRI brain and spinal cord. That was normal. 3 times MRI was done in 2016, 18, and 2019. But there was no recent MRI. I prescribed the patient by MRI, but the patient is very much reluctant, and actually patient is fatigued because there is uncertainty about the diagnosis. And the second one is anti-NMO antibody was done. It was we hope that it will be positive, but unfortunately it is also negative. And but I searched the this disease details. There is 80% cases this antibody may be positive. Even there some portion may be negative also. But we found the negative, the anti-NMO antibody. Even anti-MOG antibody, it was also negative, and vitamin B12 level it was absolutely normal. And CBC, there was no anemia, no MCB, high rise of MCB, so suggesting of any vitamin B12 deficiency or so these are the investigation that was done. Later on, other routine investigation, including urinary, like chest X-ray, was done. That was our normal. Sir, this is our next plan actually. We could not do LP or CSF study, and even he was advised, but the boy was very much reluctant, and now he was admitted this time with only tingling and numbness. And our next plan was doing CSF study and MRI again, that is new evaluation of MS for to see any oligoclonal band or IgG index or myelin basic protein. This is our main plan, sir, of doing now, and also excluding the vasculitis, screening of vasculitis by doing ANA, RA, ANCA, and AC level also. And we want to do TSH level to see the peripheral neuropathy as a it is comorbid condition, maybe peripheral neuropathy. Or maybe a second entity, that is hypothyroidism or other common causes peripheral neuropathy. So we want to do TSH level and also want to infection screening, sir. Sir, now I need opinion actually. What can I do more, or what can we should do more?
Okay, thank you, Dr. Yusuf Ali.
Professor Minal Kanti Rai, make him in the panelist.
Ehsan Khan, please add Minal, Dr.
মৃণাল কান্তি রায় স্যার মোস্ট প্রবাবলি আমাদের আমি একটু ওকে স্যার একটু চেক করছি স্যার
ছিল একটু আগে
So what you can do is, see, you can do a visual VEP, visual evoked potential, which will tell you of asymptomatic optic nerve involvement. So if there is demyelination, you can find out. And second is, you can do a good high quality MRI, and you can do the cervical spine and then take very close cuts, thin sections of the cervical spine, because the plaque may be very small and sometimes it may be missed. So you can do a thin section of the cervical spine. And also the optic nerve, you can do the MRI orbit. And this, yeah, MRI orbit, you can find out the thinning of the optic nerve. If it is, there is an old optic neuritis, you can find out thinning or some signal abnormalities in the optic nerve. So these things has to be specifically done, and with specific sequences you have to do, like STIR images are there. So those fat suppression STIR images may be done. And CSF we have already planned, oligoconal band, IgG index, these things you can do. And if it is negative, if the workup is entirely negative, then you can write as a chronic recurrent idiopathic optic neuritis. So there is a condition called as CRION, CRION.
Sir.
Yeah, that
chronic idiopathic
recurrent optic neuritis. But then the tingling and numbness of the hands and feet are the new symptom, which is not explained. So you have to do the cervical scan properly.
Okay, sir.
ওকে থ্যাংক ইউ প্রফেসর জ্যোতির্ময় পাল স্যার, আপনি এই মানে এই প্রেজেন্টেশনের কনক্লুশনে কিছু বলবেন স্যার? জ্যোতির্ময় পাল স্যার, ডক্টর ইউসুফ আপনার প্রেজেন্টেশনটা একটু অফ করে দেন, স্লাইড শেয়ারটা একটু অফ করেন।
আচ্ছা আচ্ছা, আমি কিন্তু আরো একটু ছিল, আমি কি ওটা
না, আমরা এখন নেক্সট কেসে যেতে হবে ডক্টর ইউসুফ, আমাদের আরো প্রেজেন্টেশন আছে।
আচ্ছা, এটা জাস্ট ওই রিপোর্টটা নেগেটিভ, ওটা একটা ছবি আছে, আর এমআরআইটা নরমাল ছিল অলমোস্ট।
ওকে, থ্যাংক ইউ ডক্টর ইউসুফ ফর ইওর প্রেজেন্টেশন। ডক্টর সারাল রাজি, আপনি ডক্টর ইউসুফ আপনার প্রেজেন্টেশনটা একটু ক্লোজ করেন, স্লাইড শেয়ারটা।
আচ্ছা, আমি স্লাইড
দেখা যাচ্ছে ভাবে?
সারা প্লিজ মেক ইট ফুল স্ক্রিন।
আমাকে শুরু করব?
হ্যাঁ, প্লিজ।
আচ্ছা, Assalamu alaikum and very good evening. I'm Dr. Saral Razi, working as Assistant Registrar Medicine in Shohid Tajuddin Ahmed Medical College Hospital, Gazipur. And today I'm presenting a case about a 35 years old male with limb weakness. Mr. X, 35 years old, hailing from Kapasha, Gazipur, and admitted to our hospital on 6th November 2023 with complaints of progressive weakness of both lower and then upper limbs for 3 months. And according to the statement of the patient, he was reasonably well 3 months back. Then he developed weakness over his limbs, initially affecting the left lower limb and followed by right lower limb, and gradually upper 2 limbs. Weakness is progressively increasing day by day and ultimately results in inability to walk without help of others for the past 2 months. He also complained of occasional spontaneous twitching of muscle involving different parts of the body, especially on upper limbs. Furthermore, for the last 1 month, he had been experiencing difficulty in deglutition of solid food, but not in liquid, with slurring of speech. On query, he stated that he had history of weight loss about 6 kg within 2 months, which is not associated with excessive sweating, excessive thirst, and polyuria. There was no history of nasal regurgitation, tingling, numbness of any part of body, any history of trauma preceding the illness, cough, fever, hemoptysis, joint pain, alteration of bowel habit, any contact with known case of tuberculosis patient, any viral infection, vaccination, and vision loss. His bowel and bladder habit was normal. And in case of his past history, there was no significant past history, and patient was non-diabetic and non-motensive. And patient took calcium and vitamins from local pharmacy within these 3 months before admitting to our hospital. And he was a smoker for 10 years, consuming average 8 sticks per day, and he was non-alcoholic. Patient belonged to lower middle class family. All of his family members were enjoying good health, and no history of similar kind of illness was running to his family. And he was immunized according to EPI schedule and took 3 doses of COVID-19 vaccine 1 year ago. And according to the general examination, a patient was anxious and ill-looking and cooperative. Anemia, jaundice, cyanosis, clubbing, koiloniakia, leukoniakia absent, edema absent, lymph node not palpable, and thyroid gland not enlarged. Blood pressure was 110/80 millimeter mercury on both arms, pulse 90 beats per minute, temperature 98 degree Fahrenheit, respiratory rate 16 beats per minute, and weight previously was 52 kg and now 46 kg. On nervous system examination, higher psychic function was normal. Speech, there was slurring and indistinct speech. Involuntary movement with multiple fasciculation over both upper arm muscles, busting of the muscles of both hands, both thenar and hypothenar. Muscle tone were increased over both lower limbs and normal over both upper limbs. Muscle power was diminished both upper and lower limbs, while lower limbs grade was 4/5 and upper limbs were grade 3/5. And reflexes, biceps, triceps, and supinator jerk was diminished in both right and left arm, and knee ankle jerk was exaggerated, and plantar both was extensor. And there was patellar and ankle conus present, jaw jerk brisk, palatal movement absent, gag reflex present, coordination impaired, and sensory examination was intact, gait was spastic, and fundoscope examination normal. And other system reveals no abnormality. So, in summarize, Mr. X, 35 years old farmer smoker, non-diabetic, non-motensive, hailing from Kapasia, Gazipur, admitted to our hospital with complaint of progressive lower and upper limb weakness for 3 months, which was first in lower limbs and then was upper limbs. And patient was inability to walk without help of others for the last 2 months with occasional spontaneous twitching of the muscle in the upper limbs and also in lower limbs. He had been experiences difficulty in deglutition of solid food, and there was slurring of speech without any nasal regurgitation, and patient gave history of weight loss about 6 kg. There was no history of tingling, numbness, any part of the body, any history of trauma, cough, fever, hemoptysis, joint pain, alteration of bowel habit, any contact with known case of tuberculosis patient, any viral infection, vaccination, vision loss, and his bowel and bladder habit was normal. So this is the case of this 35 years old male patient. And now আমি কি প্রভিশনাল ডায়াগনোসিসটা বলবো নাকি পরে?
এই পর্যন্ত থাকুক। ওকে, ডক্টর প্রবীণ কুমার যাদব। ডক্টর প্রবীণ যাদব। আপনার কোনো কোয়েরি আছে এখানে?
Yeah, in the examination, what about the tongue? How was the tongue movements? Were there any tongue fasciculations? Could you make out?
There was tongue was spastic, sir. There was no wasting and fasciculation.
There was no wasting of the tongue?
No wasting and fasciculation.
Okay, what about the neck power? Neck was weak?
Neck power, no, sir. No.
Okay. And did you see any obvious fasciculations in the limbs when you examined?
More on upper limbs and few in right thigh, especially.
Okay. Was there any wasting of the limbs?
না, লোয়ার লিম্স এর ছিল না স্যার, শুধু থিনার এন্ড হাইপোথিনার মাসল অন আপার লিম্স এরটা বেশি বোঝা যাচ্ছিল।
ওয়েস্টিং ছিল?
জি স্যার।
Okay. Okay. And sensory examination was normal, bladder and all those things was normal, right?
Yes sir. Yes sir.
ঠিক আছে, ঠিক আছে। স্যার পাল স্যারকে জিজ্ঞেস করুন, লাইক যদি কিছু ক্লারিফিকেশন আছে।
স্যার কি অ্যাভেলেবল আছেন? জ্যোতির্ময় পাল স্যার? ওকে, ডক্টর সমীর কান্ত দত্ত, আপনাকে অ্যালাউ করছি, আপনি কি কোনো কোশ্চেন করতে চাচ্ছেন? আপনি তাহলে আনমিউট হয়ে কোশ্চেন করতে পারেন। আর দেন ডক্টর মৃণাল কান্তি রয়। আপনার কোনো কোশ্চেন থাকলে আপনি করতে পারেন রিগার্ডিং।
Now, this is a very nice presentation. I think this is a very good gesture on the part of yourself and as well as from the Dr. Pal, and from our side, Parveen is doing a very good job. So I congratulate you all. I am a very senior person. What I find that this is a very straight cut case, and she has done a very nice history. Only thing is that I don't know what is the problem with this case. But as there is a both upper motor and lower motor signs, as well as there is sparing of all the sensory system. Only problem is that the age is only 32 years of age, 32 or 33. 35. So the age is very, in comparison with the other cases we come across in a case of a degenerative disorder like MND or amyotrophic lateral sclerosis, the age is little bit less. That is one point. Number two, the sparing of the tongue, classically with a slurring of the speech without any wasting and nothing. This is another point. Weakness of the neck flexor is not there. But still there is both upper motor and lower motor sign in the upper limb as well as the lower limb. So this is a progressive quadriparesis with upper motor and lower motor, along with fasciculation and some bulbar symptoms. So this is the thing, and you have to explore the secondary causes in this age, and strongly you have to look for the family history and secondary causes which can mimic like that. That's all.
Thank you, sir, for your opinion. Dr. Praveen.
Sir, weight loss আছে significant sir. Weight loss আছে, degradation আছে, malignancy কিনা স্যার, malignancy থেকে MND বা
ওকে, ডক্টর আয়েশা মোহাম্মদ ওসমান, ডক্টর প্রবীণ, আমি ডক্টর আয়েশাকে একটু অ্যালাউ করছি। ডক্টর আয়েশা মোহাম্মদ ওসমান।
Assalamu alaikum. Good evening, expert panel, teachers, and good evening, presenter. It's a wonderful case. If I'm not wrong, I've heard somewhere the plantars were bilateral extensor, is it?
Yes sir.
Oh, so in that case, I would like to ask the teachers, when we say ALS and then there is a plantar extensor, shouldn't we take that with a pinch of salt and consider a cord pathology? And considering the spastic tongue with significant weight loss, which she mentions is a significant 6 kilograms, could the entire entity be explained by a perineoplastic presentation involving the cord as well as the horn cells? I need a clarification on that. Thank you.
Dr. Praveen.
What was
Sir, should we consider a cord pathology simultaneously along with horn cell involvement? As my dear friend has mentioned, the patient had plantar extensors on both sides. And also a spastic tongue, again, could it be perineoplastic, as she also signifies weight loss?
Cervical myelopathy is one common condition which we see as a differential diagnosis of motor neuron disease, which we face in our practice, because it is very important. Because if it's a cervical myelopathy, you're going to operate, and if it's an evolving MND, you are not going to operate. And we have seen many patients who have undergone a cord compression surgery for MND, and later on, when the florid manifestations come over, then we understand that it's a motor neuron disease actually, not a cervical myelopathy. So it's very, very important. So how do you differentiate it from a motor neuron disease? One is the bulbar involvement. So bulbar is the most important thing. Always look for the tongue, the swallowing difficulty, fasciculations. Second is in MND and ALS, in cervical myelopathy and ALS, both you may have wasting and upper UMN and LMN features in the upper limb. But the thing is the sensory findings. So you'll get a lot of sensory involvement in the upper limb. If it is a cervical myelopathy, you will get sensory loss, you will get vibration loss, and those things you have to examine properly.
Yes.
Second thing is in the lower limb you will get spasticity only. There will be no LMN findings. While in a motor neuron disease or ALS, you will have both LMN and
Yes, sir, both.
UMN in the
And if
lower
I'm
limbs
not
as
wrong,
well.
my friend has mentioned plantars extensors. So should we confidently say ALS? I think that's a drawback there,
Yeah,
which she's already mentioned.
definitely. Yeah,
Plantar
both will have
extensors.
both will have extensor plantar. So plantar will not help you differentiate.
Yes,
So
sir.
the sensory findings, the
Is it
bulbar
a
findings.
very common entity in ALS? Is it usually a common entity in ALS, sir? I needed a word on that.
Plantar may be flexor as well, but it can occur. Usually we see in 30 to 50%, it may be extensor also. So the bladder symptoms, the sensory symptoms, the bulbar symptoms, this will give you a clue that it's likely to be a cervical myelopathy.
But then this amount of weight loss, sir, is it again an entity in ALS or MND, whatever you say?
Yeah, ALS, if it's a secondary ALS due to some paraneoplastic causes like
yes, that was a concern whether the entire scenario can be explained by paraneoplasm.
You may get weight loss. So they'll have significant weight loss. So that may be a part of the ALS as well.
Yes, sir. Thank you, sir.
Okay, thank you. Now, Dr. Sara, তোমার দিদিগুলো একটু দেখাও।
Okay. So our provisional diagnosis is motor neuron disease, and this was amyotrophic lateral sclerosis. And differential diagnosis were cervical myelopathy, paraneoplastic syndrome, especially bronchial carcinoma, and syphilitic amyotrophy. As patient was non-diabetic, so we exclude the diabetic amyotrophy. And there was no joint pain, so we could not keep the differential diagnosis of sarcoidosis.
ওকে ওকে, থ্যাংক ইউ ডাক্তার সারা। ডাক্তার প্রবীণ, আমরা এখানে এই কেস শেষ করব। আপনি কিছু অ্যাড করবেন কিনা, বা ডাক্তার সারার ডিফারেন্সিয়ালের সাথে আপনি কতটা এগ্রি করেন?
Yeah, so this is a straightforward case, as Minal sir said. It's like a clear-cut case of ALS, amyotrophic lateral sclerosis, because you are having UMN and LMN features together. Now, MND can be of various types. You can have pure UMN feature, that is PLS, primary lateral sclerosis. You can have a primary bulbar palsy, which involves the bulbar area. You may have primary LMN feature like PMA, that is progressive muscular atrophy. Or you may have in the young age, which is called as a spinal muscular atrophy, young children and all you may get, which is called as SMS. So that is a pure LMN. And when you get a combination, it is called as ALS, amyotrophic lateral sclerosis. So here it is a clear-cut case, but you have to rule out all the mimics. So what are the mimics which you have is, one is thyrotoxicosis. So thyrotoxicosis, you may have a lot of fasciculations, wasting, weight loss, and these things may be there. Patient may be very anxious, hyperactive. So those things. Second is various enzyme deficiencies, like there is hexosaminidase A deficiency, Pompe's disease, and all this can also manifest like ALS-like picture. Hyperparathyroidism is one condition. So these are the paraneoplastic secondary ALS due to a neoplasm, especially lymphoma and small cell carcinoma. So these you have to rule out, especially if it is a very young age, like in this patient, and if it is very rapidly progressive ALS, then you have to rule out the secondary causes. So you do a paraneoplastic workup, thyroid profile, and other things also. But mostly it's a clear-cut case of ALS. And we have seen in young patient also developing a rapidly progressive ALS-like syndrome.
ওকে, থ্যাংক ইউ ভেরি মাচ ডাক্তার সারা। আমার মনে হয় যে আমরা কি এই কেসটা এখানে শেষ করে, ডাক্তার প্রবীণ আপনি শুরু করবেন এখন?
If a panelist and chairperson, if they want to add any comments.
চেয়ারপারসন স্যার মোস্ট প্রবাবলি ডিসকানেক্ট হয়ে গেছেন স্যার কোনো কারণে। মৃণাল কান্তি স্যার কি ডিফারেনশিয়াল ডায়াগনোসিস, বা আপনি যদি স্যার আপনি এখন?
ঠিক আছে একদম এক্স্যাক্টলি আমার মনে হয় এখানেই শেষ করে দিন, আর প্যারানিওপ্লাস্টিকটাকে আউট করে দিন। প্রবীণ যেটা করেছে বলেছে এবং যেভাবে কেসটা সারা প্রেজেন্ট করেছে, ইট ইজ এন এক্সেলেন্ট। সো আই কংগ্রাচুলেট এভরিবডি। I think she has done a marvelous job. So we can stop here and we can go to the next spotters.
Okay, okay, Dr. Sara, please.
Okay.
তুমি তোমার স্লাইড শেয়ারটা অফ করে দাও। ওকে, এখন ডাক্তার প্রবীণ কুমার যাদব।
Okay, so good evening, sir. Minal sir, thank you. You're there. And it is a very basic presentation, and only very short spotters I have kept for especially for the internists and medicine. So it won't be very like very interesting cases. Basic cases are there. So I'll just share my slides.
এবং এখানে তো সবাই ইন্টারঅ্যাক্ট করার সুযোগ পাবে।
May I interrupt if it's allowed just for a minute?
Okay.
Yeah, sure.
Sorry, sir. Like Dr. Sara's patient, did we have any images done?
Yeah, I do all investigation were included. আমি দিছিলাম কিন্তু যেহেতু
আমি ওইখান পর্যন্ত যাইনি, আমরা ডিডি পর্যন্তই থাকছি এটাতে।
আচ্ছা হ্যাঁ, পর আমাকে পাঠিয়ে দিন।
ওকে।
ডাক্তার প্রবীণ প্লিজ।
Yeah, sure. Is it visible?
Visible. আপনার ফার্স্ট স্লাইডটাতে যাইতে হবে ডাক্তার প্রবীণ।
এখন ফার্স্ট স্লাইডে আছেন।
4 নাম্বার স্লাইডে আছেন। 4 নাম্বার স্লাইডে আছেন আপনি।
এখন দেখা যাচ্ছে?
দেখা যাচ্ছে। আপনি একটু ফুল স্ক্রিন করেন এবং স্লাইড নাম্বার 1 এ যান প্লিজ।
Okay, এখন?
Clear. Very clear.
Okay. Yeah. Okay, so we'll have a few spotters as we are already late. So I'll just have briefly go through the cases. So this is the first patient. It's a spotter. So she came with recurrent episodes of such movements in the hands. So these were recurrent movements, jerky movements of the hands in the left side, focal jerks which were occurring, multiple episodes for the last 3 days, almost 10 to 15 episodes, and each episode lasted for 20 to 30 seconds. And there were no focal twitching of the face or the lower limbs, no slurring of speech, no persistent focal neurological deficit. So this was the problem which she came to the OPD for evaluation. And the CT scan. So what is the movement there? So how will you characterize it?
স্যার একজন আনসার করেছে কোরিয়া।
Yeah, anything else?
কেউ কোনো কমেন্ট করলে চ্যাট বক্সেও করতে পারেন, হ্যান্ড রেজ করতে পারেন। টিটেনি আরেকজন লিখেছেন, টিটেনি আরেকজন লিখেছেন মায়োক্লোনিক সিজার। কোরিয়া, টিটেনি, মায়োক্লোনিক সিজার।
So myoclonic seizure, it's a unilateral
rolling movement. স্যার আরো আছে পিল রোলিং মুভমেন্ট আর হেমিবেলিসমাস, বেলিসমাস।
See, balismus is basically a flinging movement involving the upper limb or the lower limb, and it is proximal predominantly. And here what you get is a jerky movement, irregular jerky movement, which is coming and going and lasting for a few seconds. So the terminology here will be focal seizures. You can say it's a focal jerking or focal seizures. So that is what we thought of. And whenever you get a focal seizure on one side, you think of a structural pathology in the opposite side of the brain. So here we wanted to rule out any lesion in the parietal or the frontal lobes. So CT scan was done, which was normal. There was no structural lesion. We did a EEG because the events were very recurrent. So we did a EEG which showed a on and off focal seizures which were going on in the opposite cortex, which could be documented. So we were sure that it is likely to be a focal seizure. And electrolytes was normal. Sodium, potassium were normal. So what other investigation will you do? I'll give you the background history. She is a diabetic on treatment, but irregular treatment, and she's not taking medications properly. She's missing her drugs.
We should do a glucose panel with an hemoglobin A1C and an MRI brain with contrast.
Now, which one investigation will you do? which may be done in the bedside also, which will clinch the diagnosis.
A CBG?
Yeah, so that is what. So you want to do the glucose levels. So this was the glucose level in this patient. 1 second. Yeah, it was 884. And the urine ketones were negative. So she was having what is called as a HONK, hyperosmolar non-ketotic state. And this patient presented with focal seizures. So focal seizure can be the only presenting manifestation of hyperglycemic non-ketotic state. And this patient was admitted and was given with fluids and insulin, and gradually she improved. Over 2 to 3 days, she became normal, and there was no need of anti-epileptic agent in this drug. So in this focal seizure, this is one focal seizure where you will not like to give anti-epileptic agent because it's an acute symptomatic seizure due to very high blood sugar levels. So one more patient, this is again a spotter. You can see she is having focal twitching involving the left upper limbs. I think the connection is a bit slow, so the videos are, so you can see the focal jerking which is occurring. And this patient also, the scan was normal, and we did a EEG which again showed electrical seizures, and sugar was again in the 600 ranges. Again, sugar controlled, patient became normal. So this condition is well known. It is called focal seizures due to non-ketotic hyperglycemia. And so whenever you get a focal seizure, do the CT scan or MRI, and if the structural cause is ruled out, always look for sugar levels, because that is one important cause for focal seizures. So there are a lot of case reports and review studies which shows that hyperglycemic focal seizure is common. Now, why it is unilateral, we do not know. What is the cause that makes it asymmetric, we do not know. This is one more spotter. Just look at the video here. So this is an elderly patient, again a diabetic patient, coming with left-sided movements, left upper limb and lower limb, recurrent movement which is continuously present. This is not intermittent, this is continuously present. So what are these movements?
প্রবীণ স্যার, এখানে অনেক আনসার আছে, লাইক হেমিবেলিসমাস, কোরিয়া, হেমিবেলিসমাস.
Yeah, correct. So yeah, they're absolutely right. It is hemibalismus, hemichorea, hemibalismus. So this patient had a left hemichorea, hemibalismus.
Diabetic steatopathy.
Yeah, again, this is due to the same reason, hyperglycemia. I'll just go to the next slide.
Sir, আর মাঝে একজন একটা কোশ্চেন করছে ইন্টারেস্টিং, স্যার, is there anything termed hyperglycemic basal ganglia syndrome?
Yeah, this is what is called as hyperglycemic basal ganglia syndrome or steatopathy. Due to the metabolic problem, the metabolic insult to the basal ganglia, this occurs. Now,
okay, sir.
But here, in a diabetic patient, when you get this unilateral symptoms, you must also rule out a stroke. For example, in this patient, you can see there's an infarct in the right subthalamic area. So subthalamic infarct or bleed, both can give rise to hemichorea, hemibalismus. So diabetic patient, you look for the sugar and also the scan for any structural stroke which may be giving rise to hemichorea, hemibalismus. So this is two important causes of focal seizure in a diabetic patient. One is hyperglycemia, second is stroke. So the decay, we know that decay presents with various manifestations like seizures. It causes altered mental status and various things. But hyperglycemia without ketosis, that is non-ketotic hyperglycemia, presents with this sort of various manifestation, focal seizures, epilepsia partialis continua, tremor, balismus, and chorea. So hyperglycemia has various manifestations, unlike hypoglycemia, where the manifestations with this hypermotor involvement is less. Okay, so why this occurs? The mechanism is that ketosis is protective. So because of the ketones, the GABA level, that is the inhibitory transmitter level, is high in the brain. And when the sugar increases, but the ketones are less, the GABA levels get depleted and the brain becomes hyperactive. And then because of the hyperactive brain, you get either seizures or hyperactive movement disorders in the brain. Now, this is one more patient. This is not directly diabetes related, but it's a complication of diabetes. So diabetic patient, hypertensive patient on thiazide diuretics, admitted with UTI and high sugars and hyponatremia. And after treatment of the hyponatremia, patient improved. But then after a few days, they found that the patient has become excessively stiff, unable to move and unable to walk. And you can see the video of the patient, very brief video. I'm asking the patient to do like this. Move the hands. You can see the movements are very slow. He's wheelchair bound and he's quite stiff. He's unable to move the limbs and he's having severe bradykinesia and tremors. And this patient went to the hospital walking. He was having just mild some sedation, some drowsiness and fever and all, but he was ambulant. But on coming back from the hospital, he became wheelchair bound. So what could be the condition? After treatment of UTI, and this is the scan of the patient. This is the MRI scan. So can you just tell the diagnosis?
Okay, sir. This is central pontine myelolysis, ODS of basal ganglia, extrapontine demyelination.
Very good. So that is the answer. The term is ODS, that is osmotic demyelination syndrome. Now, osmotic demyelination can occur in two sites, not two sites, many sites. The commonest site is pons, when it is called a central pontine myelolysis, and it can be extrapontine also, that is in the basal ganglia. And sometimes it may be combined, central and extrapontine. Now, central pontine myelolysis will present with quadriplegia, the bulbar dysfunction, quadriplegia, patient will be bedbound, and it can also present in a locked-in state. While extrapontine myelolysis will present with Parkinsonism. When you get a rapid Parkinsonism in a patient admitted in ICU with hyponatremia, with CKD, with low albumin, with hypokalemia, a lot of comorbidities, alcoholic patients, then you think of this osmotic demyelination. And you should do the MRI scan. And you can see the MRI scan, there is bilateral hyperintensities involving this is the caudate and this is the putamen. So bilateral hyperintensities are there. So this is osmotic demyelination syndrome. Again, it is a preventable thing. So you should correct the sodium very slowly in patients who is sick and is having CKD and diabetes and all those things. Now, the thing is that when you get bilateral basal ganglia hyperintensity, it is not specific for extrapontine myelolysis. It can occur with many causes: toxic, uremic, metabolic involvement, viral infections. Patient with fever, altered sensorium, most important cause is Japanese encephalitis, and also dengue encephalitis and all can affect the basal ganglia. Adam can affect the basal ganglia. So it's not a specific finding, but with the history with basal ganglia hyperintensity, you can say that it's a extrapontine myelolysis. So the history is very important, and this history you have to communicate with the radiologist also, so that they can form a good differential diagnosis. Okay, so now this patient, diabetic patient on irregular treatment, recent onset of tremors and imbalance and inability to walk. What happens is whenever he walks, he falls down, and he's having on and on off hiccups. He's on telmisartan, Telma H for blood pressure, and oral hypoglycemic agents and insulin. The sugar is fasting is 139, BP is 204, HbA1c is 8. And these are the medications, and 2 weeks history of inability to walk, and also falling while walking. So I'm asking the patient to keep the hand like this. So with this finding in the examination, and patient is unable to walk, he's a bit drowsy, he's ill looking, and with this finding, with a background history of diabetes and on telmisartan and hydrochlorothiazide, so what could be the possibility here with this movements? Anybody? So what is this movement? So when you ask the patient to keep the hand like this and you get this sort of movement, this is called as flapping tremor. It's called as a negative asterisk. It's called as a negative myoclonus or flapping tremor. So now the flapping tremor is so severe that it is affecting the elbow, shoulders, and even the head and face. So this is a very severe form of flapping tremor. So flapping tremor in a diabetic patient, you will think of any encephalopathy due to hyponatremia, uremia, or some other metabolic.
ইউরেমিক ট্রেমরস অনেকেই বলেছে ইউরেমিক ট্রেমরস।
Underwent a workup, CT scan was normal. Yeah. So they was waiting with severe flapping tremor. And when this tremor is so much proximal, the patient is unable to walk. When they walk, the tremor comes in and he like goes to a fall like thing. So that is the cause of the fall in this patient. So always look for metabolic encephalopathy in patients with diabetes. So any diabetic patient, you can have variety of neurological manifestation due to the CKD itself, because CKD can bring with lot of things. So CKD is an independent risk factor for stroke. So you may get microbleeds, infarcts, bleeds, all those things can occur. And cognitive dysfunction may also occur due to CKD as a part of the ischemic changes or due to uremia. And early stages in CKD, you have ischemic strokes, and later on you get bleed. So you may get massive hemorrhages and bleed. And this is one important manifestation in CKD. It is called as PRESS. So it's called as posterior reversible encephalopathy. So any CKD patient coming with seizures, altered mentation, visual symptoms, and you have a very high blood pressure, you think of posterior reversible encephalopathy syndrome and also stroke. So you do the scan. If you get this sort of edema in the posterior part of the brain, and this edema subsides in few days, when once you control the blood pressure, then you say it is likely to be a PRESS, posterior reversible encephalopathy syndrome. It's a very important condition which occurs in CKD patients. CKD due to diabetes or hypertension or lupus, all this can give rise to this. And also drugs which are used in transplant like tacrolimus can give rise to a PRESS-like condition. Now the name of PRESS is a misnomer. PRESS means posterior, but sometimes it may be anterior also. You can see the lesions which is anterior here in the frontal lobe. And reversible, sometimes it may not be reversible. If you do not control the blood pressure very quickly, then the patient may develop strokes also. They may develop subarachnoid bleed, intracranial hemorrhage also. So it's not always reversible. So the name is a misnomer. You can have the edema in the frontal lobes. You can have the edema in the brainstem also. It's called as a central PRESS. So the location of the edema is not only posterior, it can be anterior and also in the midbrain and the brainstem levels. So these are the various complications which can occur due to renal disease. You may have encephalopathy, cognitive impairment, you may have strokes, you may have PRESS, you may have peripheral neuropathy due to uremia, you may have a myopathy due to uremia, and restless leg syndrome and pains in the lower limb. All these things can occur. And also during the dialysis, very important, you may have dialysis induced hypotension, dialysis headache, you may have dialysis disequilibrium syndrome and dementia, but which is not very common nowadays. And also due to complications due to transplant, if the patient undergoes renal transplant. So these are the various manifestations of renal failure in patients with diabetes. So to lie down a bit, I'll just put in a spotter. This is a quiz question for all the participants, just to lie down the load of the cases. So who is this person and what is his contribution to epilepsy? Anyone?
যে কেউ বার্জার
Yeah, this is Hans Berger, and he is recorded the first EEG, and he showed the first alpha wave in the brain. So this is a Hans Berger. Okay, so we'll go to a brief case again. So this is, we went through the central nervous system manifestations of diabetes. Now just briefly about peripheral nervous system, a brief case here. 28-year-old lady, 14-year history of type 1 diabetes with poor glycemic control, HbA1c around 10 to 14%, but without any symptoms of neuropathy and no other complications of diabetes, now presented with DKA due to a UTI. So this patient had poor sugar control, type 1 diabetes, now having a DKA due to a UTI, and is admitted in the hospital. And the sugars are rapidly controlled with insulin, and the DKA subsides, UTI is also controlled. Now she is discharged, and 3 weeks later, she has severe pain in the limbs, upper limb, lower limb, burning pain, severe pain, and she's unable to tolerate the pain. But on examination, you do not have much findings. The reflexes are normal, the power is normal, even the sensations are normal, only she's not allowing you to touch. So severe allodynia, hyperalgesia is there in the hands and feet, and severe burning. So patient is very symptomatic, but you are not able to elicit much of the findings. You did a nerve conduction study, which was again normal in this patient. So what is the diagnosis here? Patient having severe neuropathy symptoms and rapidly controlled diabetes.
স্যার এখানে আমি একটু বলি যেগুলো আসছে এই পর্যন্ত, একটা আসছে ইনসুলিন নিউরাইটিস, দেন insulin induced neuritis, TIND. Okay.
So
glucotoxicity.
Yeah, absolutely correct. This is insulin neuritis, and this is a small fiber neuropathy. So for small fiber neuropathy is difficult to diagnose because objectively you will not have much findings in the examination, and even the nerve conduction studies will be normal. So this is insulin neuritis, and for this you have to do other tests which will help us to detect the small fiber neuropathy. Like in this patient, a skin biopsy was done, which shows the dropout of the small fibers. So either a skin punch biopsy, or you can do some other tests like the biothiometer, or you can use the vibration sense filaments, or you can use something called as a pseudo scan or a skin biopsy. Skin biopsy is bit invasive test. So these things you have to do to diagnose this small fiber neuropathy. So this is called as a treatment related neuropathy, or insulin neuritis is the other name for this condition. And this occurs when you rapidly control the sugar, HbA1c. So if the HbA1c drop is from around 6 to 7, you can see the neuropathy affects almost the entire body. If it is 4 to 5, upper limbs and lower limbs, and if it's 2 to 3, the distal upper limbs and lower limbs. So more rapid control of sugars, the more chances and more severe will be the small fiber neuropathy, which is associated with this. Now, what is the diagnosis here? Diabetic patient coming with recurrent falls and pain in the thighs.
Diabetic amyotrophy.
Amyotrophy.
Yeah, absolutely correct. So this is diabetic amyotrophy. So when a diabetic patient comes to you with difficulty in walking, proximal weakness, buckling of the knees, falling down, and you have a wasted quadriceps muscle, and once you squeeze the quadriceps, there is severe pain in the quadriceps muscle, always think of diabetic amyotrophy. And you examine the legs, you may have a hip flexor weakness and knee extensor weakness. So weakness will be proximal. The knee jerk may be absent in that side in which amyotrophy is present. The misdiagnosis which may occur is that sometimes the pain may radiate to the back also, and then you may think that it's a lumbar root spondylosis or a lumbar root compression. And sometimes this elderly patient may have some findings in the MRI also. So if the patient is seen by a neurosurgeon, it may land up in a surgery because there is weakness and back pain and MRI showing some disc changes. So you have to be extremely careful in these patients, diabetic patients.
Sir,
and you should evaluate properly. And
what is the lesion, sir? Is the lesion in the lumbosacral plexus or not, sir?
The lesion is in the lumbosacral plexus.
Exactly?
So the lesion is in the lumbosacral plexus. It's also called as diabetic radiculoplexoneuropathy.
Yes,
and the lesion is in the lumbar plexus. And it is due to the microvasculitis of the vasa nervosum, the blood vessel which supplies the nerves. So it's a sort of plexopathy. So this patient will recover on its own over a period of 1 to 2 years. So it's a self-limiting condition. So you should not operate this patient if there is back pain and some disc. So always evaluate this patient properly. So these are the various type of diabetic neuropathy: large fiber, small fiber, proximal neuropathy like amyotrophy. You may have cranial neuropathies, third nerve, sixth nerve, fifth nerve. So this neuropathy. Sometimes you may have a truncal neuropathy around the truncal level. So it may mimic a IVDP involving the dorsal spine. So you may think that it's a disc prolapse. It may be acute and it may be unilateral also. And you may have various compressive neuropathies like carpal tunnel syndrome, ulnar neuropathy, and also the foot drop, the common peroneal neuropathy. So this sort of various type of neuropathies can occur in diabetic patients. So I'll not go to the details here. Okay, so this is one more spotter. Anyone? Diabetic patient.
Ptosis, a third nerve palsy.
Yeah, absolutely correct. So you can see there's a ptosis, and there is the eye is deviated towards the left. So that means there is a right medial rectus weakness, and left lateral rectus is overacting. It is pulling the eye toward the right. So that means the lateral rectus or the sixth nerve is intact, while the third nerve is involved. So there is partial ptosis also. And what one examination will you do in this patient to say it's a diabetic third nerve palsy? One examination.
Pupillary reaction.
Yeah, pupillary reaction. So in a diabetic patient, the pupillary reaction will be spared because the pupillary fibers are in the periphery, and usually the blood supply goes through the central part. So it will be spared. So ophthalmoparesis, all the cranial nerves may be affected. Most common what I see is sixth followed by third in our clinical practice. And these are the various neurological manifestations. I'll not go into detail. We are already running late. Okay, so this patient, I think I presented it some time back. Middle-aged lady with joint pain and deformities and interstitial lung disease. Presents with cough and recurrent episodes of syncope during coughing. And this is the examination finding of this patient in the hands. She has joint pain and ILD. So you can get the diagnosis.
Yeah? It's an RA hand. It's an RA hand.
RA with cervical subluxation.
Yeah, so it's a rheumatoid arthritis hand. You can see the deformities. You can see the swan neck, bottonaire, Z thumb deformity. Okay, so everything is there. And this is the scan of the patient. She also had neck pain and tingling in the limb. So we did the cervical spine. So what is it?
Factual.
What findings do you see here?
There is atlantoaxial subluxation, as they say, and
yeah,
tonsillar herniation.
Yeah, you can say it's an atlantoaxial subluxation or a CV junction abnormality due to the arthritis. Okay, so that is involving the cervical spine, and that is giving rise to the syncope. So whenever you get a cuff syncope or you get a cuff headache, then you should rule out a Arnold-Chiari malformation or a CV junction abnormality. Anything induced by cuff. So always keep this in mind. So this is the finding. So these are the various manifestations of rheumatoid arthritis. So I'll not go into details. Okay, so one more quiz question just to lighten up. So who is this girl? And you can see the plant here. And how is she associated? What disease is she suffering from? How is she associated with the neurology?
Gower sign.
No, she is suffering from a disease, and
DMD.
you can see
DMD.
Plant will give you the clue. What plant is this?
ডিজিজের নাম সবাই লিখছে DMD. Okay.
Okay, so I'll give you a clue. She is having some sort of epilepsy syndrome. So what plant is it, and what is the name, if you can say, and how is she associated with this?
Cannabis.
Very good, very good. So who has given that answer?
Muhammad Muhibul Alam.
Yeah, so this is cannabis. So it's cannabis. It's called as it's available, widely available in India. It's cannabis plant, it's cannabis sativa. And you can see here, so her name is Charlotte Figi. And she was the girl, actually she was suffering from Dravet syndrome. So it's a severe myoclonic epilepsy of infancy. And she had very severe epilepsy, multiple attacks, almost 300 attacks. And then somehow somebody gave her this cannabis oil. And after that, the attacks remarkably reduced. And because of this, in the US, now cannabis is legal, so they use it, medical cannabis is legal. And this is used for the treatment of Dravet syndrome and is FDA approved. And now, like few weeks back, it has been approved by the Indian authorities also, and it is available in India. So now we are going to use it in the next few months. This is called as cannabidiol, and it is the one of the drug of choice of Dravet syndrome. And this girl, but unfortunately, she expired a few years back due to the illness, and she developed pneumonia and she expired. But she was the person behind the legislation of use of medical cannabis in America. So this brief video, look at this video. I'll just give you a brief history. This is a elderly male, 65-year-old, 6 months history of illness, started as memory loss and difficulty in identifying objects, visual issues, difficulty finding path, memory issues. And then gradually he became slow. There were tremors. He started falling. And this dementia and Parkinsonism worsened over a period of 6 months.
Lewy body dementia.
And he became bedbound. So in 6 months, he is apathic, he is mute, he is having rigidity in examination. And also one very interesting finding in the video, which will give you the diagnosis. And he's not improving on any treatment, he's deteriorating over a period of months.
Is it an MSA, multiple systems atrophy?
Look at the findings. One finding.
Lewy body dementia likely, but finding.
You can see some jerky movements. Can you see? On and off, it is continuously present.
So majority answer is LBD.
Okay, so I'll show you the MRI. Now this is the MRI of the patient. Yeah?
Alzheimer's disease is a Parkinson plus syndrome as answer.
Is it an MSAP, multiple systems atrophy, the Parkinson type?
Patient is bedbound in the matter of 2 to 3 months, and he's almost worsening. And everybody has given hope. He has gone to all the apex institutions in the country, and everybody has said there is nothing to be done. So you can see the MRI. What do you see? Is there finding of Alzheimer's disease or Lewy body dementia, or there's something else? So you can see there is basal ganglia, diffusion weighted image showing edema in the basal ganglia bilaterally, and there is diffusion restriction also in the basal ganglia and also in the cortex in some of the parts. This is called as a cortical ribbon sign. So that is what is the diagnosis here? And a CSF study was done, and a specific test in the CSF which helped us in the diagnosis as well. Anyone?
Sir,
Creutzfeldt-Jakob disease.
Yeah, very good. So that is the diagnosis here, and these movements are the myoclonus which you see in Creutzfeldt-Jakob disease. You can see there are small, short interval cortical myoclonus. So it's a multiple. You can see the myoclonic jerks. Now in CJD, myoclonus is cortical. So when cortical myoclonus occur, it will be multifocal and it will be brief and it will not be very large amplitude. While if it's a brainstem myoclonus, you get the big myoclonus like you get in the epilepsy syndrome. But in CJD, the myoclonus will be multifocal and it will be small amplitude myoclonus. So this is what you are getting here. And you can see the cortical ribbon sign and the CSF 1433 protein. So there is one protein which can be done, and it is available in India. And this was positive in this patient. It was done from AIIMS New Delhi, and it was found to be positive. And there is one more test which is not available in India. It's called as the quick test for CJD. And that is said to be 100% sensitive. So that is the. He is on one medication. So name the medication.
Antipsychotic.
Anybody, what medication can give rise to this?
Antipsychotic drug.
Okay, so that can give rise. But he is on a medication which is used to treat Parkinsonism.
Levodopa.
Yeah, levodopa. Yeah, this sort of very fast dyskinesia you only see in levodopa. So this is a levodopa-induced dyskinesia. So when you give levodopa for 5 years, 6 years, then you get this sort of dyskinesias. This can occur during the falling phase of the levodopa when the dose starts to come down, or it can be peak dose, or it can be biphasic, or it can be irregular dyskinesia. So this is called levodopa-induced dyskinesia. And this is an indication for deep brain stimulation surgery or other treatment modalities for Parkinsonism. So this is called as levodopa-induced dyskinesia. So it can be so severe. You can see it's so rapid and severe, and it can be really disabling for the patient.
ডাক্তার প্রবীণ, এই ক্ষেত্রে ড্রাগ কমপ্লিট উইথড্র করলে কি পেশেন্ট রিকভার করবে না, যে সার্জারি লাগবে বা?
No, then once you reduce the drug, the patient will go for off phase. So it will be totally stuck, won't be able to walk and do the activities. And once you give drug, then the patient will have this sort of dyskinesias. Okay. So you have to either modulate the dose, find out what dyskinesia it is, whether it's a peak dose, whether it's a off on dyskinesia or off, or it's a biphasic, and then you modulate the drugs. But many times it becomes very difficult to manage these patients. Okay, so we'll go to the last case. So this is the diagnostic criteria of CJD. So I'll not go into details. You should have dementia, myoclonus, visual or cerebral disturbances, pyramidal or extrapyramidal features, akinetic mutism, and typical EEG which shows periodic discharges, and that will be 1 per second. So periodic short interval discharges, and the CSF 1433 protein. So this is a short case. 43-year-old male presented with 6 months history of gradual onset and progressive bradykinesia, tremors of all limbs, and walking difficulty in the form of imbalance and short suppling gait. He also had slurring of speech with hypophonia. So 6 months history. Neurological examination revealed broken saccades, rigidity, cogwheel phenomena, bradykinesia, short suppling gait. So she had features of Parkinsonism, 6 months in the illness. So we thought of atypical Parkinson's, that is Parkinson plus. And this is the video of the patient. Videos are not playing, I guess. 1 second. Oh, sorry, the video are not playing. So I'll tell you the findings. Patient is severely bradykinetic, and the saccades and all are very slow. Mass species is there, stiffness is there, tremor is there. He's bent forward, he's flexed, and he walks with a very slow and short stepping gait. But the atypical feature is it is rapid onset and progressive. The forward flexion is very much more, and it is bilateral symmetric involvement, not unilateral involvement, and reflexes are also brisk. So pyramidal involvement is also there. So he's having Parkinsonism, pyramidal involvement, and also some dementia also there, subcortical dementia. So multi-axis involvement And because of the multi-axial involvement, we thought that it's not a typical Parkinsonism. It's likely to be a typical Parkinsonism. And you can,
Dr. Praveen, unar profession ki?
he is basically working in a you can say it's a welding in job in a steel factory.
So manganese, অনেকে আনসার এটা দিবেন যে
yeah, correct. So that is one possibility. You can see the MRI. Anybody, what is the finding in the MRI?
Hyperintensities in the basal ganglia.
So what sequence is this? Can you just tell what sequence is this?
Anyone? Okay.
This is a T1.
Yeah, T1. So what are the findings?
Hyperintensities in the basal ganglia.
Yeah. So what is it? T1 hyperintensities in the basal ganglia? So that means there is a mineral deposition. So T1 hyperintensity in basal ganglia means there is a mineral deposition. So it is due to the manganese deposition here. So this gave us the manganese. So this will not be there in any atypical Parkinsonism, MSA or PSP. That gave us the clue to this condition. And you can see here also. So this is the new MRI after 2 years. And you can see there is T1 hyperintensities in the basal ganglia. And later on, you can see there's a lot of cortical atrophy also which has come in. So the brain has gone into atrophy. He's almost 5 years after the diagnosis and he has quit his job. He's unable to work and still there is no improvement in this condition. So it's almost a permanent damage. And you can see there is basal ganglia mineral deposition which is seen in the gradient sequence also. So this is one condition which can be prevented if diagnosed early. And he was evaluated extensively everywhere and for ceruloplasmin and all those things were done. And the manganese levels was done, which was twice the serum levels were twice than that of the normal levels. CSF was normal. All the investigations for secondary causes were done. So the diagnosis was manganese-induced Parkinsonism. And this is the manganese mechanism, and these are the routes in which you can develop this condition. One is inhalation route. Then you can have gastrointestinal absorption and impaired clearance like in liver disease. So in CLD patients also you can develop manganese deposition and that causes the non-Wilsonian hepatolenticular degeneration. You will get manganese deposition in the CLD patients. So any patient with the manganese deposition, you should rule out these few conditions. I'll just show the most important thing. One is environmental exposure due to various occupations like ferroalloy plants, welding, combustion, ceramic and glass industries. Second is systemic illness, most important CLD and CRF, renal and liver disease. Other is total parental nutrition. So if somebody is on TPN also, he may develop this manganese deposition. And some genetic mutations can affect the pathways of excretion of manganese, which can give rise to deposition of manganese in the system. So these 5 broad categories you should remember whenever you see manganese in the scan in the T1 weighted images. So these are the various conditions, genetic mutations and acquired and total parental nutrition. And this is how you have to, these are the disturbing differentiating features. One is the tremor in manganese will be kinetic tremor. While in Parkinsonism, we all know the tremor in Parkinsonism is a resting tremor. You get a resting tremor and also a re-emergent tremor after some time. While in this manganese induced, you will have a kinetic or postural tremor only. Dystonia will be early on in the illness. There may be gait disturbances. You will have the flexed gait. So it's called as the it's also called the Kukold gait, like the patient gets flexed, or the manganese gait. And you may have mental abnormalities, psychiatric symptoms, speech abnormalities early on, and also dementia. Subcortical dementia will be there. Bilateral symptoms will be there. Pyramidal features may be there. And response to levodopa will be very poor. So this will tell you that it is likely to be something else, not a idiopathic Parkinson disease. So I think we can end here. So I've almost completed my slides. Any clarifications we can discuss?
ওকে, থ্যাংক ইউ ভেরি মাচ ডক্টর প্রবীণ কুমার যাদব। আপনি আমার মনে হয় স্লাইড শেয়ারটা ক্লোজ করে ফেলতে পারেন। থ্যাংক ইউ ভেরি মাচ। প্রফেসর জ্যোতির্ময় পাল স্যার মোস্ট অফলি ডিসকানেক্টেড হয়ে গেছে। তো আমাদের মাঝে যেহেতু এখনো আমরা অত্যন্ত অনার্ড যে প্রফেসর মৃণাল কান্তি রয় স্যার এখন আমাদের মাঝে আছেন, আর স্যার যদি কনক্লুশন এসে কিছু বলেন।
So thank you for asking me to have a last comment. প্রবীণ তো সবসময় ভালো কেস প্রেজেন্ট করে। আমাদের এখানে ডিফারেন্ট আমাদের যাগুলো আছে নিউরোলজি ফোরাম, তো ইজ এ ভেরি গুড স্টুডেন্ট অ্যান্ড অলসো এ ভেরি রিনাউন্ড নিউরোলজিস্ট, এবং আমরা প্রবীণকে খুবই ভালোবাসি। তাছাড়া আমি আরেকটা জিনিস লক্ষ্য করছি, বাংলাদেশে যে রেসপন্স গুলো এসছে, আমি তো রেসপন্স গুলো করিনি, কারণ রেসপন্স আমার করাটা বোধহয় ঠিক হবে না, সেই জন্য আমি করিনি। আদারওয়াইজ ওর কেস গুলো জেনারেল মেডিসিন রিলেটেড বহু জিনিস, যার জন্য জেনারেল ফিজিশিয়ানরা উপকৃত হবেন। বিশেষভাবে জেনারেল মেডিসিন রিলেটেড যে কোয়েশ্চেন্স গুলো, বিশেষ করে ডায়াবেটিস, তারপরে ধরুন কিডনি ডিজিজ, লিভার ডিজিজ, ম্যাঙ্গানিজ যে প্রবলেম, এই জিনিসগুলো আমাদের সবসময় সচেতন থাকতে হবে। এবং ওভারঅল এই ধরনের যদি আমরা আরো সেমিনার করি বা ওয়েবিনার করি আপনার গাইডেন্সে, আপনারা যারা করছেন, আমার মনে হয় সবাই উপকৃত হবে। It was an excellent session. Both the cases from Bangladesh was excellent, and Praveen has also done a marvelous job in demonstrating the various videos and also some clinical symptomatology and very good cases. So I wish this forum a grand success in future, so that the internists will be greatly benefited in course of their career. Thank you very much.
Thank you very much, sir, for your kind words. অবশ্যই থ্যাঙ্কস দিতে হবে আমাদের আজকের দুই প্রেজেন্টারকে। তারা আসলে অত্যন্ত স্বল্প সময়ের নোটিশে প্রেজেন্ট করে দিয়েছেন। আসলে জাস্ট 2 দিনের নোটিশে তারা কেস রেডি করে আজকে প্রেজেন্ট করেছেন, যেটা ওয়ান্ডারফুল ছিল। ডক্টর প্রবীণ কুমার যাদব তো আসলে এখন আমাদের বিডি ফিজিশিয়ানস এর পার্ট হয়ে গিয়েছেন। এখন আসলে ওনাকে আমরা মানে কোনোভাবেই গেস্ট লেকচার হিসেবে কাউন্ট করি না, ইজ ফ্যামিলি মেম্বার। এবং আশা করছি প্রবীণ কুমার যাদবের মাধ্যমে আমরা অনেক সমৃদ্ধ হবো, যেমন আজকে যেভাবে জ্যোতির্ময় পাল স্যারকে এনেছেন, হয়তো ভবিষ্যতে আমরা আবার আমাদের মাঝে পাবো। আর কালকে সেশনের জন্য একটা ফর্ম দেওয়া আছে, এটা কালকে স্ক্যাবিসের উপর একটা সেশন 11:30 একটু ফর্ম ফিল আপ করবেন। সো থ্যাংক ইউ ভেরি মাচ এভরিওয়ান। আমাদের ফেসবুক লাইভেও আসলে অনেক ইনভলভমেন্ট ছিল, কিন্তু এত কোশ্চেন ছিল যে আমরা নিতে পারছিলাম না। সো আমরা এখানেই আজকের সেশনটা কনক্লুশন করছি। ধন্যবাদ সবাইকে। হাবিবা, তুমি ফেসবুক লাইভটা ক্লোজ করে দাও।
Recording stop.